In Section 2, we're going to continue our examination of the NHS by looking in detail at the relationship between NHS England and the clinical commissioning groups. Clinical leadership has been the political direction of travel for over 20 years in NHS policy, regardless of which political party has been in power. Before 2013, there was a system of 152 primary care trusts. These were led by managers, but supported and advised by health professionals, especially GPs, with the aim of ensuring that the community's health needs were met. In 2010, Andrew Lansley, who was then the Health Secretary for the coalition government, wanted to change this. He wanted to put the clinicians on top to lead the vision for the NHS locally, with managers being on tap to implement their decisions and plans. In order to be authorised by NHS England, the clinical commissioning groups had to prove a number of things. They had to demonstrate that they had a clear plan to meet the health needs of their population. They had to show that they had good governance in place and understood the quality and economic issues in their health economy. They had to have a competent governing body, and they had to demonstrate that they can build and maintain really good relationships, particularly with their own members, the local GP practices. A CCG is a membership organisation, and a GP practice cannot hold a contract with the NHS unless it is a member of its local CCG. The main reason we have more than 200 CCGs compared to the previous 152 primary care trusts is that the GP leaders were allowed to decide how big they wanted their organisation to be. They could either opt for being small, as in the case of Norfolk, if they believed the identity with their local community was more important. In this case, it's been essential that the CCGs work collaboratively with neighbouring CCGs in order to have a strong negotiating position with large local NHS provider organisations such as the hospital or mental health trust. In the case of Cambridgeshire and Peterborough, they opted to be bigger because they felt the identity of their county or wider area was strongest. In this case, they have set up local, small commissioning groups of GPs to ensure the services they buy are sensitive to the needs of their communities. Every CCG is allocated its budget based on the size of its population. They have to decide how to allocate this money. They do so by examining the changing health needs of their population. These are set out in the Local Joint Strategic Needs Assessment, or JSNA. This must be produced by the local Director of Public Health. It is a document that will be updated on a continuous basis, but it will set out the expected changes in the population in terms of numbers, demographics, deprivation and health trends. The CCG uses the findings of the JSNA to help them develop their strategy. This will guide their decisions about which services need to be commissioned. The main contracts will be with the hospitals locally, the Mental Health Trust, the Community Services Trust, but there are also many other providers. Typically, a CCG may hold hundreds of contracts. NHS England closely monitors the performance of each CCG and holds them to account. In Section 4, we will look in more detail at the internal governance arrangements of a CCG. This brings us to the end of Section 2, which has looked in detail at the relationship between NHS England and clinical commissioning groups.